to them for supporting this this conference. I also want to thank our members from our Center for Communities, Families, and Children, two of our council members, Jeff Lixon and Sherry Rowland are here. So Jeff and Sherry, thank you very much for being here and your support. And also, there's other members here, Craig Stanley, who's not only our Associate Dean, but a council member. Are there other people from our council, CFC council here? We appreciate your support. Thank you to the staff from the College of Social Work, FSU College of Social Work, and from the CFC Center. A lot of them are out in the front helping, and they did a lot of things. So please thank them on the way out. They worked really hard to pull this together. Accurate. No, seriously, she's actually a very benevolent mother with sometimes a mean attitude, but she gets things done. I've called her the queen of implementation. She can take a happen, and she hires some of the best people. I think the people on the team that she's putting together are just top notch, and they're doing amazing things in a very short period of time. So having said that, the title of my talk is, so why, we all think, social workers, and those of you who are from other disciplines, medicine, economics, education, get sick of hearing about social workers, but most of it, you're surrounded by social workers right now. But why is this important beyond just doing what seems logical, which is the fact, as Ellen showed in the statistics, just how few of our students are getting this kind of education, this kind of information. When I was back at the University of Kentucky and a faculty member, I was asked to lead a curriculum development effort by the college. And I came up with this revolutionary idea, which is to say, let's go out and find out who our students are actually working with. And we found that most of our students who are graduating, certainly with BSW and MSW degrees in direct practice, who were they seeing? They were seeing women with children who were struggling with a substance use disorder, probably with a significant trauma history, and with a baby or a toddler or children, often in a violent, intimate partner relationship, and struggling with comorbid health and other mental health illnesses such as anxiety or depression. And I were the people that they're going to work with. It sounds revolutionary, doesn't it? Partly why that's important is that I think, along with what Captain King was talking about, secondary traumatic stress, compassion fatigue, burnout, there's also a very important piece that's coming into the literature. The National Academy of Medicine has been publishing material on this over the last few months, is this idea of moral distress. What is moral distress? Moral distress is not necessarily that you're overworked or that you're exposed to traumatic experience. Moral distress occurs when you're put in a position as a professional and you don't have the tools to do what you need to do, and you begin to develop or accumulate a sense of guilt, anxiety, a sense of loss, that you've trained for years to do something and you can't accomplish it, and a sense of responsibility that you're coming into the situation in a way that you really can't help people. And all of us in social work, and I'm not going to say all of us, I'm going to say myself. I'm 61 years old, so I've had plenty of clients in my history, and I can think back, and most of us probably can, who've been in the profession for a while, of all those folks that we were not able to help, all those folks that we wanted to help but couldn't do it, all of those folks that we tried to help, and we actually made things worse for them because we didn't know what we were doing, and we didn't know that we didn't know what we were doing. So the biggest problem is not knowing what you don't know. And I operated in that sphere for all late to the fact that you threw an incredible, well-funded program and nobody came. That's all of us can relate to that in terms of these failure experiences. What distinguishes the people in this room is that we are interested in learning from success and failure. And that's very inspiring and very important. It's one component, I think, of what a resilient person does. And that's what we're trying to do today and with this consortium. I think the question of why does social work education need this kind of program? What can it do for us as a profession? What can it do for us as educators and for our students? First of all, this consortium and pulling together this curriculum really is an incredible example of utilizing social capital and intellectual capital. That is, as Captain King talked about earlier, about the need for social connectedness. We are creatures of social connection. In fact, our bodies, our brains are wired fundamentally around connectedness, and we need each other. We are also overcoming with this consortium a big problem in Florida, which is that of geography. Rural, urban, suburban, north, south, northwest, northeast, southwest, the beach, the mountains, every kind of geographical configuration. We are a microcosm of the United States of America. And if we can demonstrate the capacity to come together to create this curriculum and to really learn from each other, that's a remarkable event. And that little icon of the map represents a really powerful example of intellectual and social capital. So you can tell we just did a snapshot of speakers today, but the other thing that this kind of education brings to social work education, and I would say this would apply to any discipline that imports or uses this curriculum, are some really important components that are representative of what's absolutely essential in contemporary higher education. The first one is it has to be multidisciplinary. While we can be proud of each of our professions, and we should be, and professions do an incredible job socializing us and creating our identities, any of our professions are inadequate to providing sufficient analytic framework and tools and understanding to tackle the kind of wicked problems we have in front of us in terms of addiction and substance use. And the complexity of substance use disorder calls us out of our silos to work together, just as it's calling us out of our particular university or college or department to work together. Captain King is a good exemplar of it. Tanya Wren is too, and there's others with the joint degrees, MSW, MPH. This is important to live this out institutionally as well. So thank you for your generosity in being here and thinking about this. The other commitment that's to really look at research-based, science-based approaches and understanding. We have to be able to do this kind of work. We have to be able to teach our students that the research courses they're taking are not a necessary evil, or maybe what they would say, an unnecessary evil. These are important tools to communicate, to understand. And whether students are becoming literate and numerate in terms of research, whether they go on and begin to work on projects, it's absolutely necessary that they understand and become very comfortable, and not only comfortable, but psyched about the capacity for doing research and understanding how to use research in their work, in their practice environments and policy settings. So this consortium is dedicated to that. I love the fact that we are talking about social determinants of health in this curriculum. So we're taking the sociologic and the economic. So that little piece of data on elasticity, I'm a little strange. I really found that to be one of the most exciting pieces of data all day, but that tells you a little bit about how bleak my home life probably is. You can give condolences to my wife when you see her next time. But that kind of information and data connects directly to what Captain King was talking about, which is another mind-blowing idea he laid on me yesterday, which is how do we think about motivational interviewing at the population level? And that data where it says that's an obstacle about when people are making a decision to seek help, barriers. We're not even getting into the social psychological at that point or culture. I mean, we've got to solve that kind of problem too, but it's crucial for maybe refusing to go to treatment, not because they have traditionally what we think is some kind of moral problem or spiritual problem or lack of commitment. Hopefully we're beyond that. It's also maybe much more than the neurobiology of the disease. And maybe they simply cannot afford to go to treatment. And they may not even know that's what's driving the decision. So these larger economic forces are important for us to be looking at and discussing. The other reason substance use disorder curricula is so important for our educational endeavors moving forward is that this is an incredible way to introduce students and to introduce ourselves, because I'm learning things all the time, looking at this literature, to the neurobiology of addiction, use, reward, decisions they make to enter treatment, to pursue recovery. You know, substance use disorder, and Angela touched on this and others have touched on it, the use of the word relapse is so loaded because the system has been framed for decades in this idea that this is a linear process, that somehow you go into treatment, and then if you're really lucky and you're really good and you really work hard, you won't relapse. When the epidemiology and the research on the neurobiology the disorder is relapsing disorder. So this is something that researchers at the federal level and at NIDA especially have been trying to teach us, and SAMHSA, and CSAT, and HRSA, is that relapse, slips, relapses are part of this course of life of the person struggling with addiction. And the opioid use disorder epidemic is we're dealing with one of the monsters around relapse. But it's paradigmatic of all of substance use disorder. So how do we get ourselves, how do we get students intrigued by the fact that I'm making a decision that I know is so destructive to go back to using after I worked so damn hard, maybe years, yet I'm going back to that drug or medication or alcohol or whatever it is, if we look at addiction in a broader form. Neurobiology of reward is intriguing in terms of understanding that process. A few years ago, probably 15 or 20 years ago, I used to run a group in rural Kentucky for third offender DUI clients. So these were all clients, mostly men from the rural Kentucky, who had 3 or more DUI arrests and convictions. And my wife, who ran a practice where she did a lot of evaluation and assessment for the state, said, hey, we need somebody to do this group. And strangely enough, we can't find a lot of people who are signing up for it. So you have to do it. But it was an incredible learning experience. And these were men, primarily men, who had spent most of their lives. Many of them were we had some in their 20s and 30s, but a lot of them were in their late 30s and 40s because it took a little time to get caught to get 3 DUIs. It took at least a decade or 15 years. And we were using a treatment protocol that we were developing at the with rural populations. And the thing that the guys loved the most was the section on the neurobiology, the brain biology. And that was the one all of us intellectuals thought was going to be too hard for them to get their heads around. But when we used that module, many of them felt like, this is what it feels like. This is what it's like. And it got beyond a lot of the stuff. So the neurobiology piece is very important. I've already spoken briefly about the public health and frameworks. I think this curriculum, it can be informed by Captain King's been kind enough to say that he's going to be looking at some drafts of our modules. So we're really excited about that. The other piece that's come up today that's really important is it helps our curriculum focus in social work on trauma and resilience science. So that we have to incorporate these emerging understanding of trauma and resilience in everything we're doing in our curriculum. And substance use is a really great place to do that in. That the ethics, morality, and spirituality of addiction, illness, treatment, recovery, the journey of particular lives, and the moral responsibility that we have as a society to join people who are in trouble, all speak to an embrace of taking seriously the human condition, which is one of all of us share, of falling down and getting back up, of traumatic loss and resilience, of sinning and resurrecting, to use old moral terms, religious terms. We all share in that. And that is what sometimes attracts us to this work. It also is what's scary about this work, because we see ourselves so often in the life journey of our clients. And the mean mom's telling me I'm out of time. I'm just going to say a couple other things that I have to say, then I'll stop, because I'm a dean and I can't shut up. I think it's really, really important that we think about this, and Ellen and I had a conversation about this the other day. What is the outcome we're looking for? So at first, the outcome we thought was, can we get everybody in the room? Good outcome. And we did. And you're here in the room, and we're all in the room together. The second thing we began to think about, well, that's not good enough. We gotta complete the curriculum. And that's an important outcome. But then it's, let's not let this curriculum lie on the shelf. And I'll work hard with you all to work with, and we've got some directors in here, but to work with deans and directors throughout the state to adopt the curriculum, whether it be through an infusion approach, whether it be through standalone courses. But I hope we can get to a point as an outcome. Every single social work student doing will have an impact very soon. And that's exciting, especially in higher education, where progress is sometimes measured in like geological eras, right? I'd like to say by next year that we're going to be seeing this material in the classroom and students are going to be interacting with it. And finally, the super outcome, what I think is the superpower outcome, the best outcome of all, is that we'll be seeing our students in the field and our graduates effectively helping clients and families who are struggling with these disorders in a way where hope and healing, along with the best science, is operating. Thank you so much.
Thanks, Jim.
Sure.
Thank you, Jim. And we now are going to pivot only slightly to a presentation by Dr. Ferraro. He is a medical director at the Capital Regional Behavioral Health Center. He is specializing in substance abuse treatment for, nope, wrong one. I have to find your right PowerPoint. Substance abuse treatment for young adults, which again, being on a campus, college campus, this is an extremely high priority for us. and it is also highlights the necessity of getting people young, and so that trajectory of substance use disorder doesn't continue throughout their lifetimes. So with that, welcome in the program, and I will give you a 5-minute warning. You have about 25 minutes.
All right. Thank you. So we'll try to get through as much as we can today. Want to say thank you for allowing me the opportunity to speak with everybody. Just a show of hands, anybody here 5-7 years out of college? All right, excellent. I like that. And the reason, we have a lot of students. Okay, well, that's good, because I'm going to be relying heavily on you guys during this talk to shout out some answers and help me as we kind of go through this. But just to let you know a little bit about myself and what we're doing at Capital Regional. Essentially, I moved to Tallahassee in about 12 years ago from the University of Florida. Any Gators? No Gators? All right. Well, I root for the Seminoles now, so I changed. So I'm a Seminole fan. With that being said, I'm board certified in psychiatry and also did additional training in addiction medicine. Addiction medicine has always been an interest of mine since residency. Started working initially at Tallahassee Memorial Hospital, where our team opened an inpatient facility where we did detox, and then also worked in an intensive outpatient program. And fortunately, now able to work at Capital Regional Center. We're starting to implement some of those programs in the upcoming future. And in fact, good news, at the end of this month, we're actually going to be starting an substance abuse intensive outpatient program at Capital Regional Medical Center. So we're just going to get started with that. It's going to be a program Monday through Thursday. Hopefully at the end, I'll have a little bit of time so we can have some questions and answers based on the talk. So without further ado, I wanted to show you the brain of the average adolescent, the average college student. And what's interesting about this, hopefully the laser pointer will get to it. Basically, it shows that there's a lot of impulse in the adolescent and adult brain, young adult brain, compared to the adult brain. And this is supposed to be a little bit of a comic, but it actually points to a lot of the emotions that are going through the adolescent and young adult brain. You can see high levels of, well, let me see, maybe I'll step over here. Anyways, addiction, love, hate parents, a lot of very intense emotions in that corner. But if you look at the top, that little heart section, that's the judgment gland. This is not meant to be an actual brain, but you can see that judgment is one of the smallest areas. And the reason behind that is actually scientifically based. For example, we'll learn throughout the talk that the prefrontal cortex is not fully developed until people are in their mid-20s. And the prefrontal cortex is an area of the brain which is involved in judgment, impulse control, and also kind of regulating our ability to assess long-term consequences for behavior. So what makes the college student population unique? Several different developmental considerations. I don't know if they've been talked previously, but first one being identity exploration. This is a time where you have young adults, maybe for the first time, being independent, having the ability to choose, their work careers, their school careers, relationships, not only peer relationships, but romantic relationships. And all these things can cause anxiety. And as people have more and more anxiety, they may look into different ways to regulate that anxiety. And sometimes that can involve alcohol or other substances, which we'll be talking about today. Instability, significant amount of instability. And also even throughout people's college experiences, moving, to different places. People may change their career goals throughout their college experience. So it's a very stressful time, not only from a school-related perspective and a housing-related perspective, but also from a peer relationship and romantic relationship perspective as well. Self-focus. This is an area where, we kind of leave the nest, so to speak, and we get a greater sense of independence. That independence, we no longer have, our parents being the driving. feeling in between. Am I a young adult? Am I an adolescent? And am I an adult at this point? College students are certainly struggling with that dynamic as well. And then also possibilities. This is an interesting theory that a lot of college students have an unrealistic expectation and optimism. So this can prohibit them from actually seeing the negative consequences of their behavior. Kind of the idea of being bulletproof in some ways, that these consequences really won't happen to me. It always happens to somebody else, or somebody who's a lot older potentially. So neurodevelopmental factors, I talked about this a little bit earlier, and this is very important. The frontal lobe is not fully developed into our mid-20s. So that's typically why we, if you look at any of the major insurance carriers rather in the country, you're not really able to rent a car, I don't think, until you're about 25. And the reason is, it's not because they decided 25 is a good number, it's because the number of accidents that occur significantly are reduced after 25. And that's because we have a frontal lobe that's fully developed. During adolescence, you can see that the midbrain structures and impulsive symptoms are actually fully developed. So we have basically the ability to drive a car really fast, impulse control center, but we don't have the brake to tell us when we need to slow down. Talked about the prefrontal cortex and its function. And this is also something that we'll see a little bit later in the talk, which is important. Some research indicates that engaging in substance abuse in adolescence, and maybe I've talked about it, sounds like in other presentations. But basically, this is a sagittal view of the brain, which is depicting the prefrontal cortex, which you can kind of see in the anterior area there, and the nucleus accumbens in the ventral tegmental area. The ventral tegmental area is an area in the midbrain that goes to the nucleus accumbens, and that's thought to be our pleasure pathway or our addiction circuit in the brain. The prefrontal cortex also sends afferent and efferent neurons to the pleasure center to help regulate that impulse control center. So you can see if your prefrontal cortex isn't telling your addiction center what to do, because it isn't fully developed, you can have some consequences as a result. So specifically, some of the college student consequences, just in regards to alcohol use, not with other substances. 60% of college student report past month drinking. The college students that are within 5 to 7 years, would you agree with that? All right, sounds reasonable. What about a third of college students report heavy episodic drinking in the past 2 weeks? Might be a little low, might be a little high. The interesting thing about heavy episodic drinking in this paper, it wasn't binge drinking. Binge drinking is defined as having 5 drinks for men in a 2-hour period, or 4 drinks for women in a 2-hour period. Heavy episodic drinking is actually 1.5 to 2 times that. So 10 drinks or 8 drinks, respectively, for a third of college students within a 2-week period. Over 600,000 physical assaults, 97,000 sexual assaults, over about 600,000 unintentional injuries, and 1,800 deaths annually because of alcohol. And then also 21% of college student drinkers report unplanned sexual behavior, and 10% report unprotected sex, which increases the risk for STDs and pregnancy. Academic performance. This is a pretty easy slide. Alcohol use and binge drinking has been associated with poor performance. 25% of college students report academic consequences. And heavy alcohol use has been shown to directly impact the chances of dropping out of college, working in less prestigious jobs, and experiencing alcohol dependence 10 years later. Let's just kind of take it back to the slide before, where we talk about some research indicates that engaging in substance abuse, it's the last one there, in adolescence actually strengthens the addiction pathway. Well, we're seeing that play out in those adolescents and young adults who binge drink 10 years later have a much higher incidence of alcohol dependence. So you can think of drinking in adolescence as a young adult as priming the sequence of heavy alcohol use. It's defined as a period of amnesia where the person is able to engage in activity. However, the brain is not able to, violence, sexual intercourse. Had the ability to work in several different prisons, and I've talked to several inmates who are serving long sentences for things that they don't remember doing. So alcohol in the criminal justice system. It's very unfortunate when you find somebody who's serving a 15-year sentence at the age of 22 who said, yeah, I woke up in the morning, I was in the police station and didn't know what I did, but I heard from friends and from the police. Interesting thing about blackouts is it's different than passing out. Passing out is you fall asleep. Blackouts, you're able to hold information in short-term memory long enough to actually have detailed conversations. And why is this important? Going back to the slide or the last bullet point, given the nature of the preservation of short-term memory, it can be difficult or impossible to tell when a drinker is actually experiencing a blackout. So you may be talking to a friend, you may be talking to somebody that's had too much to drink, but you don't necessarily know that their memory has been affected, and they're actually going to wake up the next morning with either a fragmentary or an en bloc blackout. The difference between the two is fragmentary, you wake up the next morning and you say, hey, I can remember bits and pieces. I think I remember talking to that person. I don't remember what happened on the way home. And then the en bloc blackout is whenever you wake up in the morning and you have no idea where you are and no idea how you got there. And usually friends have to kind of fill you in on what happened. And that's just because alcohol inhibits the consolidation of memory from short-term into the long-term memory. I don't know if anybody's ever seen this movie before, possibly. Well, it's a movie that basically is, the whole premise is based on a blackout. These three individuals are going away on a bachelor party, and the next thing you know, they've had a little bit too much of substances, Rohypnol, mixing it with alcohol, and don't remember what they did the whole night before. So if anybody's trying to research blackouts, that might be a good movie if you have a sense of humor. If you don't have a sense of humor, watch it. Quantities of alcohol. So this is kind of as you proceed down the line from a blackout. It can suppress the brainstem nuclei, which are involved in breathing, and the gag reflex. A lot of people that actually die from alcohol intoxication vomit, and they're not able to, clear their trachea, and because their gag reflex is impacted. Symptoms of alcohol poisoning include vomiting, slow and irregular breathing, hypothermia, mental confusion, stupor, and death. And not too recent of a study, but from 1999 to 2008, there was a 25% increase among 18 to 24-year-olds. Fortunately, the average BAL for overdose death from alcohol is 0.33%. So that's about 4 times the legal limit. So significant amount of alcohol in a short period of time. Versus alcohol combined with other prescription drugs. You just have to be over the legal limit, essentially, if you mix alcohol with a prescription drug. And the most common prescription drugs are opiates and benzodiazepines. And the reason being is that the opiates and benzodiazepines combined with alcohol don't have a summative effect. 1 + 1 doesn't equal 2. 1 + 1 = 3 or 4. It's a synergistic effect with that combination of drugs. And if you've been on college campuses, it's not uncommon for it to be much easier for people to get prescription drugs like OxyContin, oxycodone, and Xanax than it can even be more difficult to get alcohol these days. Experienced unwanted sexual intercourse or intoxicated at the time. 6% of college students reporting being raped while incapacitated by alcohol. And what increases the risk factors? Alcohol contributes to risk by impairing perception that one is in danger, and also the ability to effectively respond to sexual aggression. Also, there's a misperception of friendly gestures as interest, potentially in sexual activity, leading to sexual aggression. And this is typically primarily in men who become sexually aggressive and can misinterpret and have severe consequences as a result. So just to show of hands, went to college, and the other person is somebody who went directly into the workforce out of high school. How many people think that college students drink more than non-college students? All right, so about 30%. We got college students. Okay, non-college comparisons. How many people think that people that skip college and go right into the workforce drink more? All right. I may have asked that the wrong way, but long story short, the answer is actually non-college people drink less. And the thought is because there's this in-between stage that occurs whenever you're in college. You know, like I said, it's kind of you're suspended in time and suspended in responsibility. Whereas people that are going directly into the workforce have more protective factors in that they may have to have jobs. Their peer group may be a lot older and more mature. They may be functioning with other people that have a fully formed prefrontal cortex, and they may also have responsibilities such as a spouse or children. So college actually is a risk factor for drinking. That was surprising to me. So what high-risk drinking behavior? This I'm going to lean on the recent grads. Anybody know what pre-gaming is? All right, what's pre-gaming? So one person just screaming out, it doesn't matter. Four Locos, yeah, exactly. Yeah, so pre-gaming. Well, why do people? Anybody know why people pre-game? What's the thought about that? It's cheaper, right? So before you want to go to an event that may cost a lot of money or not have alcohol there, you get together with a group of friends and you drink a significant amount of alcohol to try to carry you throughout the night, because you may not be able to afford the alcohol at the event, or it may not be there. So this causes rapid rates of intoxication. These are all risk factors for alcohol issues. And it's associated with higher rates of alcohol-related consequences, all the things we've been talking about. Neglecting responsibilities, feeling sick, passing out, missing school, drunk driving, alcohol poisoning, violent acts, blackouts. And then also drinking games. Anybody name a drinking game? Flip cup, beer pong, I heard. Yes, you can actually watch beer pong on ESPN. You know, it's really in our culture now that they have the International Beer Pong Association, and then I remember watching beer pong and bags is another game that people, cornhole, yes. Depends where if you're from the north, sometimes we call it bags. Yes. Oh, I have 5 minutes. All right. So I say all that to say is if you can reduce drinking games and pre-gaming, you have a much higher chance that we can rationalize drinking, especially in college. I mean, think about the academic week. How many people didn't like to take classes on Friday? You know, there's obviously the possibility of that in college. Not many people can not work on Friday whenever they get to their job. Academic year, you know, the first 2 weeks of school, it's a great time because everybody's getting together. Really, the professors haven't given us much homework yet. There's not exams until midterm, so well, maybe we just go out and celebrate every day. That also is followed by holidays and breaks, you know, after midterms, after finals, winter break where you meet up with all your friends from high school, and also in the summer where you may have less responsibility if you're not working. Also, 21st birthday's highest rate of alcohol intoxication in anybody's life, and campus events, particularly college football. You know, those have a very high incidence of alcohol intoxication, alcohol poisoning. Protective behavioral strategies, I think you guys had talked about this a little bit earlier, but one thing, if you look at Europe versus the United States, in Europe, adolescents and young adults are socialized to drink at a much younger age, so it's not a rite of passage necessarily to go to college and experience your first time where you have open access to alcohol. That's thought to be protective in some of those countries where people are learning to drink responsibility, potentially around other adults, whereas the first time some of our students at Florida State University had a drink, they were being coached on how to drink by their peers, which can be very dangerous because people can not really assess what normal drinking behavior is at that stage in their life. I'm going to keep skipping through because I have a very short amount of time, but if you look at a coronal view of the brain, you can see the gray matter and the white matter. Essentially, alcohol and binge drinking reduces gray matter volume as well as white matter volume, and the white matter are the axons. So it affects not only the cell body, but it affects the transmission of all different types of cognitive processes throughout the brain. And what are we trying to avoid? This is another, I think, a better depiction. This is an MRI. It's a coronal view of the brain. And I don't know if you can make it out, but you can see fairly significant reduction in gray matter as well as white matter volume in large ventricles. Basically, the brain's pickled. That's what when people say risk factors, but consequences to the changes in brain anatomy and also behavior as people move on through their life. Open up for any questions. I know I might be out of time, but
No, we have time for a couple questions.
Okay.
We welcome that.
Okay.
Go ahead, you.
Apples and oranges, does this keep you eating pause with legalization of marijuana?
Oh, certainly.
Question.
You can look at marijuana legalization from a political, economic standpoint, but whenever you talk about how does it affect the college population, well, the college population, their brains are still developing, and there is significant data, multiple articles on the developing brain and how marijuana affects the changes in neuroanatomy as a result of marijuana use. Most significantly are people that have the propensity for schizophrenia or psychotic disorders. It's usually considered to be a two-hit hypothesis. So basically you have the genes for schizophrenia, but something may have to turn it on. And the theory is that marijuana introduction I've seen it numerous times where people come into the hospital after significant marijuana intoxication, and maybe K2 or spice, which is synthetic marijuana that's probably 10 to 15 times what you would get on the street. Activates both of the cannabinoid receptors in the brain, and you can see a profound psychosis. Some of these people clear, some people don't. And the question is, was this somebody who was going to develop schizophrenia anyways, or is this somebody that as a result of the injury, secondary chronic marijuana use, developed schizophrenia or psychotic disorder in the absence of, or would not have done that if they weren't exposed? So yes, it does cause me significant pause. But I think that train's left the station. It's going to be legalized.
Jordan.
Any research that's out there on medications to combat alcoholism among college students or maybe adults?
Great question.
Certainly. Yep. So you brought up two medications. One's now naltrexone, that's the oral form. The other one's Vivitrol, which is a once-a-month injection. Both have been shown to be effective, usually in highly motivated patients. Naltrexone actually, it's like Chantix. They tell you, well, keep smoking with Chantix, and then you pretty much lose the taste for it. Naltrexone goes through that same pathway in the brain. People will drink, but what they say is, I don't have as much pleasure. Why don't I have as much pleasure? Naltrexone blocks the opiate receptor in the brain. So if you're blocking the opioid receptor and you're drinking, you're not experiencing as much pleasure. Two other drugs, Antabuse, that's a harm reduction model. Basically, you drink, you get very sick. People are smart enough than Antabuse, because if they don't want to get sick, they don't take it. If you have a highly motivated patient, though, they will take it. And then the third is Camprol, a camprosate, which is a medicine that you take 3 times a day, and that can help with alcohol cravings as well. So.
Jim, do you have a question?
Longitudinal studies of 20, 30 years ago.
Yes, I can't really cite a specific paper, but if you look at the World Health Organization Dawn studies, over the course of the last 40 years, these rates have increased as far as not only frequency but intensity of alcohol consumption. And what's really, alcohol has consistently risen, but the rise of benzodiazepines, opioids, and also all of our synthetic drugs has skyrocketed in comparison to alcohol, which could be more dangerous.
And doctor, just one last question that I had is if you could explain a little bit about your behavioral health center, that it's really on the periphery of our college campus here, maybe a couple blocks this way. And it's an incredible resource because students don't have to have transportation to access it.
Mm-hmm.
And it was just started a couple months ago, correct?
Yeah, so we have an intensive outpatient program office here that treats primarily college students dealing with mental health. But in the future, I'd like to see Tallahassee have a more robust detox center. So we've got plans as far as, we can do detox at Capital Regional, but I'd like to expand the beds there. I'd like to be able to help serve the college population and possibly duplicate that mental health IOP program and develop a substance abuse intensive outpatient program also close to campus so students wouldn't have to drive across town. And then also, if anybody has any interest, I'd love to hear in Tallahassee, because if you do have substance abuse issues that require a 30-day stay, you have to go out of town. And that's, being that we're in the state capital, that's pretty much a crime. But we're working on trying to get all of those components for a full recovery here in town, so we don't have to go to the University of Florida. So,
Well, thank you, Doctor.
Yep.
So just a little bit of housekeeping. We are going to have a interactive conversation with our consortium members who are sitting here at the front. We'd love there to be audience participation. You're welcome to stay and listen. We're going to have a Q&A session. So we're going to take a 5-minute break so that we can consolidate some of our tables with the consortium